Good morning and a very warm welcome to all. To mark the World Brain Tumor Day, observed annually on June 8th, we bring you a special episode on understanding brain tumors, awareness, diagnosis, and treatment this Friday morning. The Kauvery Hospital has collaborated with The Hindu for today's webinar as part of the wellness series. Brain tumors can affect individuals of all ages, and like in the case of several other medical conditions, one needs to understand the warning signs early for timely diagnosis and treatment. This helps to improve patient outcomes and quality of life. So, our panel of experts, whom you can see on your screens, will talk about the causes, symptoms, diagnosis, and management of brain tumors in the next half hour or so. Those who have tuned in for the webinar are requested to send their questions in the Q&A box, which will be open throughout the program. Our panelists will take them up in the second half of the webinar. So type out all your worries and concerns, doubts, and clarifications that you seek, and I will squeeze in as many questions as possible. So let us now move on to the introductions and the presentations. Our first speaker is Dr. G. Jos Jasper, the head of Department, Brain and Spine Surgery, Kauvery Hospital, Trichy Cantonment. A graduate of Christian Medical College, Vellore, he completed his PG and MCH in neurosurgery from Stanley Medical College, Chennai, and followed it up with a super specialty course in medical legal systems from Symbiosis University, Pune. With 2 decades of experience behind him, Dr. Jasper has played a pioneering role in enhancing neuro and stroke care in Trichy. His efforts include establishing the first exclusive stroke care center at the Kauvery Hospital in Tennur, Trichy, as per the European Stroke Association guidelines. He has also introduced cutting edge techniques such as the extended endoskull surgery and minimally invasive spine surgery, and has led many firsts in Trichy, including aneurysm coiling surgery, intra-arterial mechanical thrombectomy, and the introduction of neuronavigation system for advanced brain and spine surgeries. He will now speak on the early symptoms of brain tumors. Welcome, Dr. Jasper.
Yeah. Thank you, Kauvery. Thank you, Hindu, for giving me this opportunity. I'll jump on straight into my slideshow. Yes. Can you see my screen?
Yes, sir.
So today, like June 8th is always held as a Brain Tumor Awareness Day. And we want to use this time to bring a very close, focus on brain tumors. The word brain tumor itself is scary. When somebody tells you it's a brain tumor, it really is the end of the world for most of the patients because of lack of awareness. So that is where we want to bring in one, how do you really find out whether you have a tumor or not? And are there any warning signs? So my talk is going to be about symptomatology. And these are the main red flags that I'm going to talk about. Headache, morning headache and vomiting, weakness, unconsciousness, seizures, and any behavioral changes. Now, I'm going to give a very brief bird's eye view because to give a very detailed presentation, time will not be adequate. I just want to focus on the most important things, the message that I want to highlight. So when we talk of headache or talaivali in Tamil, I'm using bilingual here because I want people to understand what I'm saying. Headache is a very, very important component of brain tumor. And almost 70–80% of the patients really present to us with headache. Now, most of the time, the headache can be a morning headache. This is something you have to remember. When you wake up in the morning with a headache, chances are it is a sinister, a dangerous headache. A headache which comes later in the afternoon can be due to your glasses, eye power, and all that. Sinus headache is different, migraine headache is different. But an early morning wake up headache is slightly scary. And especially if you get a headache in the morning and you feel nausea or vomiting and you vomit and your headache goes away, then chances are it is most likely a severe headache, can be related to a brain tumor. So progressive morning headache relieved by vomiting. But what about patients who already have a previous history of headache? There, you can have a change in the pattern of the headache. So even any change in the pattern. For somebody with migraine, used to headaches for 20 years, suddenly if there's a change in the pattern also, you have to be worried. Pediatric is more dangerous. Babies and kids, children going to school. Most of the time, morning headache by children is not, sort of accepted easily by the parents. They think the child has issues in the school or maybe, can be gastritis and all that. Very commonly, they miss this headache. For example, this was a 4-year child, headache 6 months on and off, then developed changes in vision, eye, walking and all that. Only then we picked it up. And this is another child who came to us with just 4 days history of headache, morning headache, one episode of seizure, do a scan, there's a huge tumor. So headache, any new onset headache, any early morning headache, you cannot take it for granted. You have to make sure you get it evaluated. Next is weakness of your hand or legs or whatever it is, kai kal balavinam or weakness. Again, weakness is very significant. Usually it is not as abrupt as headache. It can take over a period of time. It is mildly, slowly progressive. But for example, here was this lady who had weakness of the right upper limb and lower limb for 2 weeks. Headache was on and off for 4 weeks. Do a scan. There is a huge brain tumor inside. Then going on to unconsciousness, otherwise known as MICOM or coma rarely. Unconsciousness is not very, like you cannot really attribute all unconsciousnesses to tumors. A mini stroke or a stroke can also present with unconsciousness. So you have to remember that also. Or a pure unconsciousness can be part of a cardiac problem also, a cardiac rhythm change also, or even pure postural syncope, like you're standing in the sun for too long, you've not had water, even that can be a possibility. But any unconsciousness, you have to definitely get it evaluated by somebody, by a physician. So always when a patient becomes unconscious, brain tumor can be there in the mind, but more commonly it is a stroke. For example, this was a 12-year-old boy, headache on and off for a few weeks. He was unconscious, and you do a scan. There was a huge tumor in the midbrain there, causing collection of fluid in the brain, leading to unconsciousness. He needed an emergency life-saving shunt. We put a small tube just to drain the CSF. Then you have to plan for definitive surgery later on. Then again, seizure or fits. We all know what is seizure. We have all seen it in Tamil movies so many times. So any first time seizure has to be evaluated, or any patient who already has a seizure, but if there's a pattern, a change in the pattern of seizure also needs evaluation. So for example, this was a 22-year-old male came with focal seizures, which means he had only seizures involving his left upper limb. And you do a scan and there's a tumor in the brain. So any seizure also needs evaluation. And when you do a seizure, when we do MRI scan, we usually check all these tracts. All this Dr. Jyoti sir will be talking, so I'm skipping. Another change that is very commonly seen is any change in behavior. Or, somebody who used to be very confident, somebody used to be very outgoing, interested in life, suddenly becomes dull, apathetic. So there is a change in behavior. So very commonly, this happens more often in elderly, where we just take it for granted. Maybe it is because of their age, they are losing interest in life, or somebody died and they are in the grieving state and all that. But any change in behavior which you cannot explain needs evaluation. 55-year-old patient, he had lost interest in life. He used to be a very outgoing guy, going for movies, singing songs and all that, became very dull. His relatives brought him because they felt that he's lost all interest in life, just sitting in one place, staring into space with headache, and you do a scan and there is a tumor sitting inside. So any change in behavior also is quite significant. Then our face and our head have lots of nerves which specifically function to supply the face and the scalp and all that. For example, your eye movement, sensation of your face, we call that as cranial nerves. And these nerves can also be involved. For example, again, this patient, 28-year-old lady, mild headache, not very severe, but she noticed vision loss in her right eye. And there you can see a very small tumor, a non-cancerous tumor, sitting right near her optic nerve, the nerve which supplies vision, and she lost vision for that. This is another patient. They said when we talk on the phone, normally we used to talk with our right, but now I cannot hear anything. So I listen to the phone using my left ear. And when I walk, I feel like I'm wobbling. And again, so these are all nerves which supply your hearing and your organs of balance, seventh and eighth cranial nerve, we call that as. But not everything is a tumor. That is also something we have to remember. For example, there's something known as a thunderclap headache, a very severe sudden onset of headache. The patient always says, this is the worst headache of my life. And very often that happens because there's a rupture of a brain vessel, brain vessel inside the blood vessel inside the brain. We call that as an aneurysm. So when you have a rupture inside the brain, also you can have a sudden worst headache of your life. Again, I said headache, very common in elderly, headache, depression, walking difficulty, loss of urinary control. They can also have a small bleed inside the brain. All these are easily treatable, non-malignant or non-tumorous condition. Elderly again, when they have memory disturbance, walking difficulty, loss of urinary control and all that, again, you can have collection of CSF or the fluid of the brain inside, and that can also cause problems like this. So these are all mimics in the sense they can mimic a tumor, but they're actually very easily treatable small problems. So the message I would like to convey is when in doubt, you have to meet a neurosurgeon or a neurologist. You cannot just decide by yourself because the best protection is always early detection. And always remember, this is my closing slide. You have to remember that any headache which you cannot explain, sudden onset, weakness, unconsciousness, seizures or fits, any change in behavior or cranial nerve deficits, you have to be careful and you have to meet a neurologist or a neurosurgeon to make sure you're evaluated properly because early diagnosis is the only way we can beat these problems. Thank you.
Thank you, Dr. Jasper, for that nice introduction to the topic. We now move on to our next speaker, Dr. Ranganathan Jyoti, the Chief Brain and Spine Surgeon and the Director of Neurosciences, Kauvery Hospital, Vadapalani. A self-made neurosurgeon holding MCH and DNB in neurosurgery, he has been practicing for the last 3 decades, during when he has performed more than 15,000 surgeries and developed many individualistic ideas and concepts in clinical practice. Known as a pioneer in endoscopic discectomy and C1 C2 fixation, Dr. Ranganathan also has expertise in microneurosurgery, skull base surgery, and spinal stabilization procedures. He works on promoting continuous knowledge enhancement and quality service, and has trained more than 100 postgraduates in neurosurgery. He has numerous publications to his credit in national and international journals and given innumerable presentations at various conferences and workshops, and also some prestigious orations, including Professor P. Ramamurthy oration at the Institute of Neurology, Madras Medical College, and Dr. Rajagopal oration at Tanjavur Medical College. He will talk about the investigations that are required or done for detecting brain tumors. Welcome and over to you, sir. So you have to unmute yourself. So please unmute yourself. So unmute yourself. Unmute.
Am I audible?
Yes, yes.
Thank you, madam. Thank you for this opportunity given to me to talk on the investigations about the brain tumors. Are my slides?
Yes, sir.
Yeah. Um, Dr. Jose Jasper, having given the bird's eye view about the symptomatology of brain tumors, once the patient has those symptoms, they come to the doctors. And how are we proceeding when the patient comes to us with the symptoms attributed and told by Dr. Jose Jasper? The investigations in the past, around 70s and 80s, it was only X-rays and angiogram, which was an angiogram, ventriculogram, which are all invasive techniques. Angiogram, you put a direct puncture in the neck and take X-rays. Ventriculogram, you put a hole in the skull and do the investigation. These are all invasive techniques and aggressive technique. And once you do that, this is an angiogram, putting a dye in the vessel in the neck, see the vessels in the brain, and displacement of this vessel, you diagnose the tumor. In putting air inside the ventricle by putting a hole inside in the skull and taking investigation, air ventriculogram, you give a contrast inside the vein. These are all invasive investigations. And after 80s, this started coming the CT scan, MRI scan. Now the CT scan, MRI scan are so advanced with so many features. The CT, MRI itself can do angiograms, and you need not do a puncture in the vessel and do the angiogram as invasive as it was being done. If at all you want to do, still you want to do an angiogram, you can do a DSA by putting a puncture in the groin or in the wrist. Then the PET scan, positron emission tomography scan. These are all advanced and non-invasive. So the diagnosis you get about the tumor is very easy when compared to what was happening before 70s and 80s. So CT scan, this was the first non-invasive investigation that was made available. Scanning time is few seconds nowadays, performed in an emergency situation. Patients who are restless and may not be cooperative for a longer duration and not fit for an MRI, like a patient having a pacemaker who cannot have an MRI done. The CT scan gives adequate information what is, but it is when compared to MRI, slightly less informative than an MRI due to the radiation from the CT scan. It is not fit for pregnant ladies. So this is one of the CT scan where you see a spherical tumor almost attached to the skull bone, and a very silent looking tumor which is easily removable. It's a benign tumor from the look of itself. An aggressive tumor, both anterior and the midst of the tumor. It's called a glioblastoma, very aggressive tumor, highly malignant tumor shown in the CT scan. MRI scan, this is the gold standard in brain tumor detection nowadays. Almost gives the pathological diagnosis. You will know whether it is a malignant tumor or a non-malignant. And among the, you can also say what type of tumor it is, and 90 to 95% it gives a pathological diagnosis. You will be removing the tumor as a neurosurgeon, sending for pathological diagnosis, but even before that we can know what type of tumor it takes. A longer duration to scan the patient when compared to a CT scan. A restless patient need to be sedated or anesthetized for doing this scan when compared to the CT scan, would take only a few seconds for scanning. Apart from diagnosis, this MRI also helps a surgeon in planning for a safe removal of the tumors. This is one of MRI picture showing a large hyper intense lesion in the midst of the tumor. This is a silent, benign tumor which is easily removable, giving a total cure for the patient. This is the same type of tumor lying on the base of the skull, base of the brain. It's called olfactory groove meningioma. The previous one, parasagittal fox meningioma. This is the olfactory groove meningioma, which after removal, patient gets a total cure. This is at another case, a large olfactory groove meningioma. Patient was almost vegetative for about 7 years, and after 7 years, the almost patient was in a deathbed. He came to me now about 2 months back and got operated from me, and now the patient is doing very well. Also, this was presented in the paper in the press, and the patient is doing well, almost walking now. And this is one of a malignant tumor being seen here, with so much of edema around, with the mass effect. This is what the pictures shown previously was all a benign tumor when compared to a malignant tumor seen in the MRI. Next, MRI spectroscopy evaluates the chemical composition of the tissue, measures the metabolites produced by the tumor cells. Different types of the tumor or different grades of the tumor have different metabolites, and the quantity of metabolites also differ. Aids in tumor grading and also type of the tumor. So it differentiates between a malignant and a non-malignant tumor and various grades of malignant tumor. In such, this is one of the a scan by which you can almost diagnose what type of tumor, whether it is malignant, non-malignant, on the grade of the tumor. Then after this, a functional MRI. The functional MRI helps a surgeon to, as I told you, helps a surgeon to plan for the surgery for the best result. Scan is performed while a task is being given, like during surgery itself, during the scan itself, like speech or movement of limbs, and the area of brain controlling the activity is highlighted. This gives a clue for the surgeon whether the tumor is in the safe area to be totally removed, reduces the morbidity of the patient after removal of the tumor. This is one of the functional MRI marking the motor cortex, where it governs the governs the motor movement of the limbs. On either side, you are seeing the red color, the functional area, and in the midst, you are able to see the tumor. And this is the tumor, and you have to be very careful in removing the tumor, going inside the tumor and remove, not to disturb the functional area. So it gives a clue for the surgeon how careful he has to once he goes into the brain. This is another MRI wherein the motor area is away from the tumor. The tumor is here and the motor area is bit away from the tumor. So you can be very easily remove the tumor without disturbing any motor movement for the patient after the surgery. Another one is a tractography, which helps the surgeon. Another sequence helps the surgeon to trace the tract within the brain and the tracts projecting down the brain. Damaging the tract can cause a severe neurological deficit post-operatively. So pre-operative tractography images helps the surgeon to help to plan the surgery beforehand and be careful with the tracts. So this is one of the tractography wherein the various colors of the tract is given, and you are able to see the tumor here, and the tract is displaced away from so you can easily remove the tumor totally without producing any neurological deficit for the patient. Then the PET scan. This is a positron emission tomography. This combines the metabolic function traced by the PET with the structural anatomy scanned by the whole body CT scan. Radioactive tracer is injected, often fluorodeoxyglucose, a form of glucose, which is radioactive, and a cancer cell consumes more sugar than a healthy cell. And this is the principle of a PET CT. PET scanner detects the tracer accumulated in the cancer cells, and CT scan maps out exactly where it is in your organ. If the tumor appears to be a secondary, as shown in the MRI, to detect where the primary is, PET is done, and this single investigation gives the diagnosis. Previously, before PET, if we think it is secondary in the brain, second.
Somebody's microphone is on. Dr. Jyoti, you have got unmuted and somebody else's microphone has come on.
Jyoti, your second line is muted, and Jyoti, you have to unmute yourself.
Dr. Jyoti, you have to unmute yourself. Dr. Jyoti.
Yes.
Yeah,
Yes.
you're audible now. Yeah.
And this is the PET CT showing a multiple intracranial lesions. Knowing that the MRI showing multiple lesions, we took the PET, and PET showing the multiple tracer uptake by multiple tumors. The whole body PET CT shows that there is a tumor in the lung, in the kidney, apart from the brain. So we know that it is a primary from the lung with the secondaries in the brain. So PET, with a single investigation, we are able to say that the tumor is somewhere else and it has thrown secondaries into the brain with a single investigation. Unlike in the past, before PET, we had to do so many investigations to find out a primary, and then or otherwise we have to go directly to the brain and then find out that it is a secondary, and then go for the primary. With this brief about the investigation, I close the. Thank you.
Thank you, Dr. Jyoti, for that insight into how doctors find tumors in the brain. And before we move on to our third speaker, I request the audience to send their questions as we will take them soon after this final presentation. Dr. Krish Sridhar is Group Mentor for Neurosciences and the Director of Institute of Brain and Spine at Kauvery Hospital, Radial Road, Chennai. He is known for treating conditions related to trauma, tumors, and infections in the brain, congenital abnormalities, vascular hemorrhages, movement disorders, pain, and epilepsy, among other conditions. He also deals with spinal disorders arising from trauma or developing tumors, disc diseases, or again, congenital conditions in the spine. Dr. Sridhar holds membership and important positions in several organizations, including the Neurological Society of India, the Association of Spinal Surgeons of India, Skull-Base Society of India, Society of Pediatric Neurosurgery, and the Neuro-Oncology Society of India, among others. The floor is yours, Dr. Sridhar, for your presentation on management of brain tumors.
So, good afternoon, and thank you very much. I'm going to can you see my slides, please?
Yes, sir. Yes.
Thank you. So, my job after Dr. Jose has spoken about the symptoms and Dr. Jyoti has spoken about how we recognize and diagnose with radiology and imaging. My job is to say how we manage it and what are the recent trends in management. So basically the question to be asked is, what is the goal in management? So there are 4 goals. Improvement of the patient's symptoms and neurological problems is the first. Reduction in the effect of the tumor on the normal brain, because every tumor causes some effect on the surrounding brain. It may be pressure on the brain, it may be involvement of the brain itself and irritation of the brain. So there are various effects of the tumor on the normal brain. We also need to know the pathology. Now, from radiology, we can get an inkling as to what type of tumor it is, but we have to get the final proof. And currently, it is not only seeing a slide, but we also get molecular pathology, which in detail tells us what is the type of tumor, what is the effect of the tumor on the patient's lifespan, and what can be the individualized treatment for that sort of tumor. So the pathology that we get from getting tissue from the tumor itself is now very, very important. And further to that, we need to plan for further treatment if it is needed. So these are the goals of how we manage a patient. Now, as you have heard, there are different types of tumors. They may be cancerous or malignant tumors. They may be non-cancerous or benign tumors. So these are the 2 broad types of tumors. You can see on the left here, this is a non-cancerous tumor, while this one is a cancerous tumor. In each, you have multiple categories and multiple types of tumors. Further, cancerous tumors may be primary from the brain itself, or they may be secondary from elsewhere in the body. But it's very interesting to note that tumors of the brain in general do not spread to other parts of the body. And that's why I put an asterisk, because there are certain exceptions to every rule, but generally tumors of the brain do not spread to other parts of the body. Now, the basic principles of management is that the first step, and perhaps the best step and mainstay of treatment of any brain tumor, benign or malignant, is the surgical removal. That means surgery or an operation to remove the brain tumor. We also have radiation therapy and chemotherapy, and these are called adjuvant therapies as they help only after the surgery is done. Now, we now have scientific evidence of the highest degree, and that is called class 1 evidence, that the extent of resection is proportional to the success of treatment of the patient. That means the more tumor that is removed, the better is the overall outcome of treatment of a particular patient. So the purpose of resection is to remove as much tumor as possible, to remove the mass effect and obtain brain tissue. Now, the question which we are often asked as surgeons is, can you remove the tumor completely? The answer is yes, especially in non-cancer tumors. Majority can be removed completely. And even in cancerous tumors, depending on the location and the size, complete tumor is removal. An example is shown here. You can see the arrow pointing to this large tumor here. And in this scan, you can see that in this place, there is no tumor. You can only see normal brain. The next question is it not too risky to do brain surgery? The current risk and complication rates for a majority of brain tumor surgeries is between 2 and 3%. And this is because there are so much advances in technology that the risk of postoperative problems has reduced, while at the same time, we are helped in maximizing tumor removal. Let me also put that it also depends on the infrastructure available for the surgeon. It also depends on the surgeon's expertise and experience to have these results. Now, currently, in the management of tumors, you have something called the oncofunctional balance, which means that you have to maximize removal of the tumor while preserving the patient's function and avoiding complications. Now, this seems very logical. You are not interested in actually removing a tumor while giving a patient a lot of problems postoperatively. So this concept is something which is now central to our neuro-oncological or brain tumor surgery. So how do we do this? So just like Dr. Jyoti explained, we have first information gathering as the first step of the strategy before we operate. So this is called advanced neuroimaging, where we do a contrast MRI scan. And then we do other scans like the DTI and tractography. This is the DTI, which you can see here. You can see the brain nerves or tracts, as they are called. This is the tumor here, and you can see how they are going so that you decide how you can operate. You can do what is called a functional MRI, which tells you where the function is. For example, in this is the motor area. This is the tumor, so you know that you have space, you know where it is. So you can be careful. And then you've got other things to also image, for example, the blood vessels. You can see whether they are involved in the tumor or not. So all this information is available even before you operate. And then with this information, you can go into the operation theater. So during surgery, you can integrate all this into different types of technology that you can use inside the operation theater. Some of these are like this, like you can do an awake craniotomy where the patient is awake when you are operating. You can do a navigation integrated technology, which is like a GPS, which you can use on your phone so that you know the machine will tell you how best to go to the tumor. We check the nerves and tracts continuously by doing what is called mapping and subcortical stimulation or intraoperative neuromonitoring. We can do intraoperative scans, and currently the best way to do it, what is being used worldwide, is not the MRI intraoperative, because that is very, very expensive, but the simple ultrasound, and that is very, very useful. And we also use something called fluorescence, and I'll just explain this to you in a bit. So today's operation theater is actually filled with technology. It's a technological laboratory almost. So this is what our operation theater looks like. You've got an operating microscope here, which is we are operating, looking into that. We have monitors everywhere. This is a navigation. We have got neuromonitoring here to look at all the waves which come out of the brain. This is intraoperative ultrasound, where we can see actually a tumor here. This is the ultrasound machine. This is the tumor. And this is after we remove the tumor. And then you have integration of all this. So you can see that this is the tractography here. You can see the pink and the yellow line showing the tracts. This is the tumor. And then the blue line shows where you are. Therefore, that is navigation showing where you actually are. So the operating microscope, very often people don't know what it is. So suppose it is like this. Just take this as an example. This is a basket of flowers. And then you have, if you zoom in, and then you zoom in further and further and further, you can actually see each of these pollen pods here and the small stems that you are actually seeing. So if you want to remove that stem alone or even that stem alone, you can do that by sub-millimeter instruments, which can help you remove only the abnormal tumor, keeping intact the normal tumor. And what also helps us is something called the fluorescein filter, which is in the operating microscope. We use the sodium fluorescein technique. You have other techniques as well, where it is colored dark yellow, green, and then that is the tumor. So you can use all this to remove the tumor. The other very common question now asked is there use of an endoscope in the brain tumor surgery? Yes, there are some tumors where you can use an endoscope, which lies just at the base of the brain, just above the nose, that we can use using an endoscope. And sometimes if the tumor is inside the ventricle or the fluid-containing space of the brain, like here, we can use the endoscope to remove these tumors. Awake brain surgery is when the patient is awake and performing tasks when we are operating and removing the tumor. And this helps ensure that the patient is all right and without complications. This is an example of how it is done. Here I am operating. We are taking you around. We are operating here. The anesthetist is here. The psychologist is here testing the patient. And then the patient is there, awake and talking.
செக் பண்ண போறோம் நான் மசில் இது காலுக்கு ஆற்றலை செக் பண்ணுவேன்னு சொன்னேன் இல்லையா அது இப்ப செக் பண்ண போறோம்
Again, somebody's microphone is on.
நல்லா very good. செக் பண்ணலாமா?
So you can hear that the patient is talking to my anesthetist.
The right hand இருக்கு இல்லையா?
So they're going to show how they're going to test the hand function.
Right hand.
He is moving his hand as I'm removing the tumor. You can see that we are removing the tumor here in the inset. So we can actually modulate and refine our tumor surgery by doing this awake. It was a lot in the press when they said you can play the guitar while do it. Yes, you can. You can sing when you're doing it. You can do calculations when you do it. So all this is possible depending on what you want to test. Integration of all these technologies and the information that you get from before surgery helps maximize tumor removal. And age is no bar for surgery. Patients often say, oh, it's a small child, or they're very old. Age is no bar for brain tumor or any sort of brain surgery, because we have the technology, we have the expertise now to deal with different ages, and you deal with it differently. Radiation and chemotherapy. Now, this helps prevent relapse or a recurrence of a tumor, especially in malignant or cancerous tumors, once surgery has been done. So that is a very important thing. It is not before surgery. It is only after surgery has been done, because you need to know the molecular pathology. Occasionally, we give something called focused radiation therapy. It can be either SRS or SRT, where we can give it for certain benign tumors in critical locations. Unfortunately, chemotherapy has not shown significant promise, though it helps augment radiation in certain situations. But with molecular diagnosis, there is a lot of excitement and a lot of trials going on with targeted chemotherapy, which can be individualized. We have our brain tumor warriors and their families come together for a brain tumor support group called the Connect. And they are filled with hope. And we have to give them hope, because now in this age, in 2026, there is so much that we can do. And never give up hope, because your miracle can be right around the corner. And this is my message to all brain tumor patients or relatives of brain tumor patients. Stay positive, because your miracle can happen. Thank you very much.
Thank you, Dr. Sridhar, for that explainer. And I think all the three presentations put together have answered many of the questions that have come in the chat box. But I think first to begin with, I would also like to quickly bust a few myths. Like, though we broadly understand that genetic mutation causes brain tumors. But are there really any external factors as well, like stress or anxiety or sleeplessness, that could also be a causative factor, Dr. Jasper?
Not really. It has been proven that radiation, usually, for example, somebody has a head and neck cancer, they received radiation, they have a higher risk of getting tumors. Apart from that, genetic, there is predisposition, and rare meningiomas can occur in people who are slightly obese, but all these are data which is not really very correct. Cell phones and non-ionizing radiation, lots of literature, but again, the data is still, equivocal. In the sense, some say maybe there is a slightly higher chance of getting meningiomas, and some say it is not true. So most important is genetic, I think, and exposure to radiotherapy per se.
Okay, why I ask this is because there's a question from somebody who says he suffered from insomnia 4 years back and started taking benzodiazepine medicine recommended by a neurologist, and his health and sleep significantly improved. But the fact that the dependence on the medicine hasn't gone away completely. So whenever he tries, he experiences withdrawal symptoms and is worried that the continued usage of the medicine could lead to some long-term issues in brain. If should he be worried about anything, he's asking.
I'll answer.
Yes, sir.
So I think depending on any drug for anything, functionally is going to be difficult because in the long run, he will not be able to sleep without the drug. And at one point of time, he'll need higher doses of drugs. So better would be to find out why he has insomnia. Now we have lots of investigations for that, also sleep lab study and all that is available. Then focus on the particular pathology he has. A focused treatment might be better in the long run.
I think, if I may add, I
Yes,
think dependency on a medication, psychological dependency, and getting withdrawal symptoms is a red flag which needs to be addressed and should not be taken lightly.
right. So also when we were talking about the diagnostic techniques, so when people, of course, when they come with any neurological symptoms such as seizures, as you said, has to be evaluated immediately, or some vision and hearing loss, or any other cognitive problem, they're of course sent for brain imaging scans. But this spectrum of psychiatric illnesses like depression. So, do all those outward signs of brain tumor, which can remain unnoticed, could these be some outward signs of brain tumor which kind of can remain undiagnosed also?
Question 2.
Dr. Sridhar, you could continue.
Yeah, I think it is very important to understand that psychological or psychiatric symptoms also arise from the brain. It is because of an abnormality of the chemicals in the brain that these things happen. And therefore, there is a huge number or percentage of patients, like Dr. Jose actually showed, that you can get psychological issues as the primary symptom of a brain tumor. So if a patient shows significant psychological changes, especially when there is no trigger for that, I think imaging to prove or disprove, that is also important, to show that he does not have a tumor and treat him as a psychiatric patient is also important. So I think it's to prove and disprove that there is a tumor or not.
Dr. Jyoti, there is no denying that the mortal fear, fear, psychosis about a brain tumor. And as has been mentioned, that not every brain tumor is cancerous. So, is there any statistics to cite, like what percentage of all brain tumors are either benign or malignant? And also, like if a brain tumor is benign, does it cause serious health issues?
Yes, madam. The patient presenting to your doctor itself is because of some neural, as Jose Jasper said, either a headache, a seizure, or a headache with vomiting, or a neurological disease like a limb weakness, or visual disturbance, or hearing this thing. So, for which they come to a doctor. So, when a patient comes to us with these symptoms or a psychiatric symptoms also. Yes, a patient goes to a psychiatrist for a psychiatric symptoms like a depression or anxiety, or they also do a CT scan or MRI. They don't just jump to saying that it is only a psychiatric. So all psychiatrists also ask for all these basic investigation. Now a CT scan MRI has become a basic investigation for a neurologist, neurosurgeon, as well as a psychiatrist. So once you do the scan, then we confirm, because most of the MRI nowadays, about 90% of MRI can say whether it is a benign or a malignant tumor. So, not that you can come to your final conclusion unless it is removed and sent for a pathological diagnosis. And among the tumors, the brain tumors, the benign tumors account for about 60%, more than even 60%. Remaining 30 to 40% only are malignant tumors. And benign tumors, if removed totally, that is the end of the treatment for them. And before removal, we have got so many investigations, more many scans, which helps a neurosurgeon to see to that they don't produce any neurological deficit because of the surgery. So like functional MRI, DTA, those help a neurosurgeon to remove the tumor. And a malignant tumor, if it is diagnosed and removed, the principle is remove as much but less morbidity to the patient. That is why where the functional MRI and the DTA really, an intraoperative fluorescein, this helps in removing safely removing as much tumor as possible. But the surgery alone does not end the treatment, and subsequently, depending on the molecular diagnosis, you have to subject the patient for all the patients for radiotherapy, chemotherapy, and of late now the targeted therapy is coming into. Even the targeted therapy has come into, and it is coming in a very fast this thing. But still, chemotherapy and radiotherapy is the gold standard right now, and targeted therapy is an added treatment for this malignant tumor. So malignant tumors, whatever it may be, when this is there, among the malignant tumors, there are high grade and low grade. Low grade tumors, when treated, it is more like a benign tumor, because almost they are cured. At least for 15 years to 20 years, they live without any recurrence. But malignant tumors, we have to, as you malignancy, we give a longer duration of life because of this adjuvant therapy like radiotherapy, chemotherapy, and targeted therapy.
So Khushbu Khan wants to know, how do malignant and non-malignant tumors show up differently in imaging?
Yes, a malignant tumor, the malignant tumors, as I shown you, the CT scan MRI, it's really irregular, ugly looking, gross edema with the mass effect. And the symptomatology for a malignant tumor is also short duration. They'll say last month he was all right. And the among the malignant tumors, one tumor is glioblastoma multiforme, another one is metastasis secondary. This tumor, we will have a very short duration of symptoms, like a month or 2 or 3, and within that they come to us with the symptoms. Whereas the non-malignant tumors grow for years together with the less symptoms of a light headache. They ignore that headache, and occasionally 1 or 2 seizure symptoms, that also they ignore, and they treat as though it was something because they had not taken rest adequately. So the symptoms, when you see the benign tumors,
So the question is not about symptoms, it is about how it shows differently in imaging. But maybe that is a little bit technical.
yeah, that
It
only
is
will see.
technical.
It is more
Yeah.
technical. You
And
have
it's
to
come
see
from a medical student, I think.
Yes.
So yeah. So I think we'll move on to the next question. Dr. Jasper, Annie Sherlin is asking, how can we differentiate between a migraine type of headache and tumor type of headache?
Migraine history is long term, and very often it starts in their childhood, and very typical. Most of them have a aura. They know when they're getting a headache. And the headache is very typical, one-sided, can be bilateral, can be two-sided also, pulsatile. They have that feeling of that pulsatile thing, nausea, vomiting, vision changes, etc. And most of these people have a very long history, 10 years, 15 years, 20 years. CT would have been done, MRI would have been done, and they're doing well with drugs. and your tumor history, it's more shorter, and you can have some of the features of migraine, but not all of the features of migraine. Most important would be the short-term history, progressively increasing headache, becoming refractory to treatment in the sense they don't respond to usual drugs, and they can develop new associated problems. For example, they can lose vision, they can develop weakness, seizures, etc. So that is how you differentiate. But
Right.
any patient with a migraine develops a change in character of the headache, needs evaluation.
So Sureshpa is asking that is lung cancer, if a lung cancer patient is getting seizure, does it indicate that cancer has spread to
Yeah.
brain? And is it treatable? And will it lead to numbness of lower body and inability to move legs?
Yeah,
So,
I think any neurological symptom in a patient who has got a cancer somewhere else means, unless proved otherwise, that the patient has got the same cancer in the brain. Because like I said, brain cancers most often do not spread to other parts of the body, but other cancers in other parts of the body very easily spread to the brain. So you have to be cognizant of that and must be investigated completely for that. Now, if we find a secondary tumor. It is called a secondary because it's come from somewhere else. It's not a primary tumor. If we find a secondary tumor in the brain, if it is large, single, and can be removed, that's the best thing to do, followed by radiation or chemotherapy, whatever is the treatment for the primary disease. If they are multiple and small, sometimes we just take a stereotactic biopsy, which means you just put a needle in and take a biopsy, prove that it is the same thing, and then you do the follow-up treatment. So yes, you have to be cognizant. It can cause all these symptoms, and you must be aware of that.
so there are a lot of questions on symptoms which perhaps people are getting, and I'll combine a couple. So Onkar Vaidya says if a person while walking suddenly stops and stands without falling, but becomes clueless or unaware of the surrounding and unable to navigate for a couple of minutes. So, is this symptom of anything specific?
Yeah.
And another question I'll combine because suddenly a lot of questions have come in. Another person is asking, while writing, my hand shakes. Is it related to any neurological disorder?
So the two are completely different. So the
Different.
first one, where the person becomes unaware, is probably a type of seizure or epilepsy. So, and has to be investigated. And if it happens for the first time in somebody who's older, it is better that an imaging is done to prove that the person. So these are called adult onset or late onset seizures, and has to be investigated that there is no structural problem like a tumor in the brain. The other one probably is a tremor during writing. Can be multiple things, the most common being what is called writer's cramps, which has to be then evaluated and treated appropriately, sometimes with medication, most often with medication.
And I think one of you also mentioned about this radiation from cell phones. So somebody wants to know, does radiation from the CT scan, Dr. Jyoti, can that cause brain tumors?
Yeah, the CT scan emits radiation. The amount of radiation it emits is equivalent to 100 of taking an X-ray chest. So, yeah, CT scan is contraindicated for a pregnant lady where a fetus is inside because that affects this thing. But other routine for one or for diagnosing a brain tumor, taking few CT scans does not produce any malignant malignancy in the patient who are taking a CT scan. But MRI has no radiation. When compared to a CT scan, MRI is the best without any radiation. But the time consumption to take is more in a MRI, whereas a CT scan nowadays is taken in within 30 seconds. You get into the gantry and you come out in 30 seconds to 1 minute. So it is faster CT scan is faster, MRI is slower, but radiation is there. But for it is contraindicated only in a pregnant ladies.
Dr. Jasper, can molecular pathology be used in diagnosing brain tumors?
When we find a brain tumor, in certain conditions, like what Dr. Sridhar said, we go for total excision, we remove the whole tumor. But sometimes we cannot do that when we do a biopsy. And this is sent for further investigation. Previously, they will look at the specimen with the microscope and give you a diagnosis. But now things have changed. Lots of analysis is done. Molecular study, DNA, RNA study, methylation studies, and all these will tell you two or three things. One, what is the actual cell which is causing the tumor? Two, how fast will it propagate or will it really multiply fast? Three, will it respond to chemotherapy? Or four, will it respond to radiotherapy? So molecular study is there to stay. It is part of the study of all brain tumors, but you have to operate to get a molecular sample.
One very
Based on-
interesting
yeah,
recent
sorry.
advance, if I may,
Yes, sir.
is there are studies going on in India itself, multi-center trials which are going on to see if we can diagnose the type of tumor just by blood, taking blood from the peripheral veins, just like you do a blood test for, say, your blood counts. So there are some studies. It's called liquid biopsy. So there are some studies going on. It is not yet scientifically proven or come into practice, but maybe 5 years from now, if you do another webinar like this, maybe we'll talk to you about it.
Great. Dr. Jasper, you did mention about morning headaches. So somebody wants a reconfirmation that whether these headaches disappear or become less during the rest of the day, and in the morning time, they have the maximum intensity.
There will be a small variation with the time of the day. Most of the time, it is very high in the morning. But then as you slowly start your work, it goes away, but it never goes away fully. It is always there. You always know you have a headache. And again, when the tumor progresses or it causes mass effect, like it causes compressing the brain or it compresses the pathway of the water, the CSF of the brain going out and causes collection of water inside the brain, CSF inside the brain. We call that as hydrocephalus. So depending on that, invariably over a period of time, the headache will keep on increasing intensity. At one point of time, the patient usually becomes unconscious. So it is always better to get it evaluated when you have the early symptoms. You do not postpone it.
Professor Sridhar, there's a question for you based on your presentation. You said the initial analysis of the tumor requires the scan of about 2 to 3 MRIs, PET CT, whatever. So the Nath Malar is asking, is there any possibility to reduce these number of tests because to make it cost efficient and also while maintaining the accuracy in analysis? You have to unmute yourself. So please unmute yourself.
Sorry. So what we are trying to do here is to maximize tumor removal while maintaining function of the patient, reducing the risks. Generally, when you do the MRI for a known patient of brain tumor and we are going to operate, these are not separate MRIs. They are only separate imaging sequences which are done together. So it is not done separately. Very often, if we are sure that it is a primary brain tumor, we don't do a PET CT. I don't do personally. So we do the functional MRI, we do the tractography or the DTI, which comes together. So it's not separate, and generally by not doing it, you have more disadvantage rather than benefit, including cost.
So again, a couple of questions. Like people are worried whether keeping the phone near the bed while sleeping, how risky is it? Then
I think it
another
is.
question.
I think forget about the cell phone. There is no evidence, scientific evidence, to say that it causes a brain tumor. There is a lot of chatter going on, but there's no evidence to show that is going on.
So likewise, somebody is having frequent dizziness And due to overwork and lack of sleep. So do I need to go for a checkup for tumor in my brain?
He
And
needs to ask the HR for a work-life balance.
so there are also, I think most of it emanates from WhatsApp University. So people say that if you do Sudokus, puzzles, crosswords, your brain is active. But does brain
That's very true.
activity?
That's very
It is?
true.
Okay.
Actually, for people who grow into the 60s or 50s, keeping your brain active is a way of postponing any chance of dementia. So you have to keep your brain active. So the concept of, what we used to have, retirement, I think is something which makes you prone to get dementia because you stop working, you stop using your brain. So doing all these crosswords and puzzles and Sudoku or taking up language or music or something is good for the brain.
Right. But also, I believe there was a study from Stanford University School of Medicine in 2017, which showed that brain activity can stimulate the growth of brain tumors. Is
No,
that
no.
true or?
I think it is a rubbish study.
Okay.
It may
Okay.
be from Stanford, but still rubbish.
Uh-huh. Do brain tumors return, Dr. Jasper, once a patient has undergone surgery or has been subjected to radiation and chemotherapy?
Thing is, it again depends on the molecular study. For example, a benign tumor, I'll just give a name, a meningioma. If you can do a total excision, most of the time it does not come back. But a meningioma, if the molecular status is unfavorable, even a benign tumor can come back. Same applies for malignant tumors. A malignant tumor can respond to chemotherapy and radiotherapy, but again, depending on its molecular study, if it is dangerous, if certain genes are there or absent, certain mutations are there or absent, it can come back. So you have to keep a very close vigil. Most of the time, these patients will have to see their doctors once in 6 months or a year, and some of them will need frequent imaging also, CT or MRI also.
Yeah, so regular follow-up is necessary because Kamal Anand is also asking whether we can say that tumors can be cured with
Yes,
any mode of treatment.
yes, most of the tumors are cured. No? Dr. Sridhar showed a slide with so many people sitting happily behind him.
Mhm.
So most of the tumors, yes. And lots of benign tumors. Say you take 100 people, I think 60 to 70% of them will have cure. But 30, 40 will be on the cat on the wall. It will be, they'll have to meet their doctors again and keep on getting evaluated again. Yes.
So, Dr. Jyoti, somebody has written about his son who has been having persistent headache, but the MRI has not shown anything. And the headache did get cured after a year, but now the doctor is advising, but now he started showing anger bouts, and doctor is advising psychiatric medicine. What
Yeah,
would you?
yeah. If the MRI is going to be normal at the time in the beginning, after 1 year, his character is changing and is still headache. Probably he has got some slow growing tumor. He should have another MRI taken right now. And if this is also going to be normal, let him have the treatment from the psychiatrist and let him have the treatment. And it may be a sort of a migraine or a cluster headache which has to be treated for the headache. And if for the psychiatric symptoms, he should consult a psychiatrist. If this MRI, which after 1 year is symptoms are changing like aggressiveness, that is one of the symptoms. A slow growing tumor can happen. If that is proved not to have a tumor inside the new MRI, if that is not going to show any tumor, he should have the treatment with the psychiatrist.
Dr. Jasper Nidarshan wants to know how to differentiate between brain tumor symptoms and symptoms from stroke because both involve seizures and unconsciousness.
A stroke is more common. 1 in 4 or 5 will get a stroke. So patient is normal, brushing his teeth, suddenly develops a headache or a weakness, suddenly develops a seizure. Obviously, stroke has to be in the mind, in which case you have to go to the hospital within the first 3 to 4 hours because treatment can be done only in the first few hours. So if you think of a stroke itself, anyway, you're going to get evaluated. And if there is a hidden brain tumor, you'll pick it up. Usually, a tumor headache is slowly progressing over a period of at least weeks, not seconds or minutes. I think that's the most important differentiating factor.
Right. There is again some technical question I want to say. The researchers working on the domain of medical imaging face difficulty with the brain tumor images. Mainly for the MRI related brain tumor images, only the structural MRI images are seen. So where can we find the perfusion and diffusion related data? Is it too technical?
No, it is not that. The data is not available to many of us. It is
Okay.
all in research. Maybe he's talking about connectomics and other things and even perfusion related resting state MRIs, but he would have to go to the people who are doing that research. And nobody's going to give data in the open market.
Mm.
He's,
Yes.
I just add. I think he's talking of certain basic data that is available free online. There are certain registries where you have a small atlas, but they will not have these details that he's asking for, because this will be proprietary information like Dr. Sridhar said.
And does sleep apnea also cause brain tumors? Because Trishna Chaudhary says her father-in-law had excessive daytime sleepiness and later diagnosed with obesity and sleep apnea, and later on diagnosed with meningioma.
That is, meningioma is been an incidental finding in a sleep. Sleep apnea is for which he has got obesity. He has got sleep apnea is there. That is why he has got a daytime sleep night, because he is not sleeping properly in the night time. And for when in a part of investigation for this sleep apnea, the doctor would have done MRI or CT scan, and the incidental finding of an meningioma would have been there in that patient. Not that after removing the tumor, he is going to have a normal sleep. If he is going to be obese, he will continue to have the sleep apnea even after removal of the tumor. So he should get treated for sleep apnea also, along with the treatment for meningioma.
Right. So we have another 50 new questions, but we don't have the time to answer them. So maybe those could be answered later directly by the doctors when the team passes those questions on to them. But I would like to wind up by 2026 World Brain Tumor Day calls for focusing on proactive empowerment through education to reduce the diagnostic gap and the mortal fear. So I would like to ask all our panelists to wrap up the webinar with your 30-second messages. So, yeah.
I'll go first. Yeah.
Yes, sure.
Brain tumors are treatable, but to treat, you have to find them. And to find them, you have to know your symptoms. So don't forget that. You have to know the disease to actually make a diagnosis. So remember the symptoms we said. Look at the symptoms, and if you have any doubt, get yourself evaluated.
Thank you.
And when the patient has got a symptoms of any headache, vomiting, seizures, don't get treated by yourself, or don't just ignore it. Come to the doctor, a neurologist or a neurosurgeon, and then he will decide whether you have to go for some basic investigation. The investigation being done are all non-invasive and easily done. And just a CT or MRI will show that an yearly detection gives a better treatment and better outcome for the patient without any neurological deficit. So don't hesitate to meet a neurologist or a neurosurgeon. And investigation asked for is going to be a basic investigation nowadays, and that done gives for the better outcome for the patient.
Yeah, Dr. Sridhar.
I think the fear of getting your head opened to have a brain surgery should go away. There are many myths, but those should go away, because with current technology, the way we can monitor your brain activity during surgery, I think the risks have become very, very low. It's equal to having just some abdominal surgery. So don't be scared of having a brain surgery for your brain tumor, because that's the best way to get treated.
Very important to raise that awareness. So thank you, doctors, for the very enlightening session on brain tumors. And I'm glad that we could catch or touch upon so many aspects, from how medical technology is revolutionizing the field and enabling early detection, accurate diagnosis, and treatment approaches are also changing accordingly. Thank you for the clarity on the topic and quelling the myths and highlighting the important developments in modern medicine that are transforming patient care and outcomes. And thank you, audience, for your questions. I think they led to more meaningful information for the benefit of all. Today's webinar on understanding brain tumors, awareness, diagnosis, and treatment was presented by Kauvery Hospital in collaboration with The Hindu. Under the Wellness series, today's special episode was conducted to mark the World Brain Tumor Day, which is observed on June 8th every year. So thank you all once again.
Thank you.
Thank you, madam. Thank you. Thank you. Thank you, Jose. Thank you, Sridhar.
Thank you.